It's 12:01, so we're going to start. Thank you all for coming. Good afternoon. We are having grand rounds, our endocrine grand rounds, and we have the fabulous Dr. Aliya Khan with us. So just a few announcements. So number one, just land acknowledgement. We acknowledge that we are gathered and are grateful to live, work, and play on the traditional, ancestral, and unceded territory of the Coast Salish peoples, Squamish, Tsleil-Waututh, and Musqueam nations, and asks those not on these lands to reflect on the territories they are currently in. So we'll take maybe a sec to reflect on that. We have Dr. Aliya Khan coming as part of our Martin M. Hoffman Endowment Fund and as part of our annual lecture series. And so the Dr. Hoffman Endowment Fund has been very generous of providing funds for bringing very prestigious and wonderful speakers like Dr. Khan. Just a little bit about Dr. Hoffman. He is an internist who joined UBC faculty way back in 1978. And he, you're all probably aware of the various Dr. Hoffman Awards, teaching awards, research awards. So his fund and his legacy lives on. And he was very involved in developing clinical care and research. And he was thought to be, for generations, a leader and a mentor. And always when he presented, he gave wonderful presentations that were inspiring. He combined a strong research as well as clinical background. And he's been known to, diagnose just like a lot of the clinicians do. I think we're very based on technology now, but just by looking, they could tell if there was an acromegalic or a hyperthyroid. So, we like to, we learn and we appreciate that a strong clinical experience. So in honor of his legacy as a researcher, as a physician, and as a teacher, the series was established at UBC. So we would like to acknowledge Dr. Hoffman and his children for continuing on this support. So now I'm going to introduce our wonderful speakers. So Dr. Aliya Khan, I've had the privilege of knowing her, and she's like a mentor to me as well for a number of years. She's a clinical professor in the departments of both endocrinology and geriatrics at McMaster University, and she's the director of the Calcium Disorders Clinic and also the fellowship director of the Metabolic Bone Disease fellowship program, which is world-renowned. She graduated from the University of Ottawa with honors and has done her postgraduate training at the University of Toronto. She's published over 400 to 500 peer-reviewed journals, and particularly in parathyroid disease and metabolic bone disease. And she's developed guidelines both with hyperparathyroidism, hypoparathyroidism, hypophosphatasia guidelines recently as well. And she's co-chaired the diagnostic criteria for hypophosphatasia. So she, in the metabolic bone world, we all bow. She's been recognized by numerous international awards, including the Women Physician of the Year by the American College of Physicians, and the Outstanding International Clinician Award by the American Association of Clinical Endocrinologists, as well as the FIRMA Parathyroid Medal for her contributions in parathyroid disease. And she's ranked one of the 0.1% top world experts in parathyroid disease and metabolic bone disease. So it is a real privilege to have her come and present in a number of lectures. And this morning or this afternoon, she's going to present on update on hyperparathyroidism. So with that,
Thank you so much, Dr. Gill. It really is my pleasure to be here. Thank you for the very kind invitation and the very kind introduction as well. So if you can all see my slides and you can hear me. Okay, the IT person. There, we knew we needed the IT resident. Okay. They were there a minute ago.
Yeah, they were good. Sometimes it just needs to be turned off and on. Like, try.
Oh, perfect. Okay. So I'm going to be talking about primary hyperparathyroidism, and I will take aspects of our new guidelines and highlight those aspects which are clinically most helpful. So these are my disclosures. And our learning objectives are to talk about how do we make a diagnosis of primary hyperparathyroidism, how do we evaluate for end organ manifestations of primary hyperparathyroidism, and how do we evaluate for genetic causes, and how do we treat it? What are the medical and the surgical options available to us? So I wanted to begin with a case. And this was a case of a young pregnant woman who presented to us in Hamilton at McMaster University. And she is 30 years old and she's 33 weeks pregnant. And she came to the Emerge because of leg pain. And on questioning, we asked her, are you feeling thirsty, or going to the bathroom more frequently? And so she said, yeah, it is true. I have had polyuria and polydipsia for a year, but the real reason she came to Emerge was because of her leg. And her ionized calcium was 2.1. And her corrected calcium was 4.02 millimoles per liter. PTH was like 40 times normal at 147 picomoles per liter. Her vitamin D is insufficient. Her alk phos is very high, with that very high PTH. Her GFR is 60. She is dehydrated. Her magnesium was normal, and her calcium to creatinine clearance ratio was 0.051. And so the leg was x-rayed, and you can see over here that she has this distal femoral diaphyseal lesion. It's a large area of lucency. It involves the cortical and the trabecular bone, 6 by 3 centimeters, and it does have cortical involvement. And usually brown tumors don't have cortical involvement. So because it did have cortical involvement and there were no clearly defined margins, I was thinking, okay, she might very well have parathyroid cancer, and this is METS, but it could still be a brown tumor, an osteoclastoma. So what do the guidelines say we should do? Well, I'm going to be presenting the guidelines. We published these in 2022, and they were published in 5 manuscripts in JBMR 2022. And I'd like to begin by reminding everybody that we have the calcium sensing receptor, which enables us to regulate PTH and control serum calcium. And the calcium sensing receptor has been called a calciostat because it works like a thermostat. So when the temperature of the house goes up, it's sensed by the thermostat and the furnace goes off. So the calciostat, if you look at what this does, or the calcium sensing receptor, which is a G protein coupled receptor, when calcium binds to the calcium sensing receptor, it will activate the receptor and activate these proteins, which will result in a decrease in adenylate cyclase, decrease cyclic AMP and protein kinase A, and decrease the synthesis and secretion of PTH. And it does it through both of these proteins. And then it will result in an increase in intracellular calcium, which will also decrease PTH synthesis and secretion. And this is how we regulate serum calcium, through the calcium sensing receptor. This is the main regulator of calcium. There are other hormones as well, but they don't play as big a role as PTH. And so if someone has primary hyperparathyroidism, that means they could have an adenoma, they could have hyperplasia, or they could have parathyroid cancer. And in these lesions, there is a decreased expression of the calcium sensing receptor. And so serum calcium is going up, but there are fewer receptors and PTH is not being decreased. So the synthesis and secretion of PTH continues. Now, what does PTH do? Well, its job is to make sure that that calcium stays in the normal reference range. And while extracellular calcium is low, PTH will go up. And PTH enhances renal calcium reabsorption. So every day we filter 10 grams of calcium through our kidney, and 9.8 grams is reabsorbed in a 24-hour time period. That's a lot of calcium. It's 10 times what you would take in orally. So we filter 10 times that amount, 10 grams, reabsorb 9.8 grams, and that requires PTH. And so if we have high levels of PTH, then what will happen is we will have increased renal calcium reabsorption. And we also see that PTH will activate the hydroxylation of vitamin D. So it will take 25 hydroxyvitamin D and stimulate the conversion to 125 dihydroxyvitamin D. And what does 125D do? Well, it helps with bone remodeling, but it also enhances the efficiency of calcium and phosphate absorption in the bowel. So this augments the effects of PTH. It'll help to bring that calcium back up. And the other important point to remember, in this first phase, PTH has a phosphaturic effect. It's such a beautifully designed system that in the first phase, in addition to renal calcium reabsorption, we are eliminating phosphate, because the second two phases are associated with reductions in phosphate. And so if you see what happens over here, the second two phases will be associated with an increase in phosphate. So when we have an increase in the formation of 125D, I don't know why the slides are going off. But when we have an increase in 125D, we will increase the absorption of calcium and phosphate from the bowel. So in the first phase, we have got a phosphaturic effect. It's preparing for the fact that now we're going to have bone resorption. And with bone resorption, there will be calcium and phosphate released from the skeleton and GI absorption of calcium and phosphate. So we prepare for that by eliminating phosphate, having a phosphaturic effect in the first phase. Shall we call IT? Because I think this is going to happen throughout the lecture, unfortunately.
Connection type.
Let me see. Good point. Very good point. Thank you. Yes. There. Is that looking good? Okay. So how do we make the diagnosis of primary hyperparathyroidism? Well, we need to have a high serum calcium. And we can do a corrected calcium, total calcium, and adjust it for albumin, because 40% of calcium is bound to albumin. So there is value in checking the corrected calcium. And we can also do the ionized calcium. And now when the ionized calcium is drawn, it's very important that it be done according to the protocol, because if you let it sit around, then you'll have lactic acid release, and it will have an impact on the measured ionized calcium. And so we need to have hypercalcemia to make a diagnosis of primary hyperparathyroidism. And some patients who have mild primary hyperparathyroidism will have fluctuations in their PTH levels. It'll go up and down. So if this is the upper normal reference range, it'll go up and down in that normal reference range. But if you have mild disease, it'll go up and down a little bit higher. Sometimes it's high, sometimes it'll dip into the upper normal range, then it'll go back up and down. So, but you have to have at least two values of high corrected calcium or a high ionized calcium in the presence of a high PTH. And this is critical. And then we also have to make sure that our patient is not taking drugs that can mimic primary hyperparathyroidism, such as hydrochlorothiazide and lithium. What does lithium do? Well, it increases the set point for calcium to suppress PTH. And so if your patient is on hydrochlorothiazide, then usually it's in the presence of an antihypertensive in a combo pill. So get them to stop the hydrochlorothiazide component and re-prescribe the antihypertensive without the hydrochlorothiazide and repeat the lab profile in a couple of weeks or a couple of months. The next point we have to ask ourselves is this isolated primary hyperparathyroidism, or is this syndromic? And that is very important to determine, because if it is syndromic, then this could be the first manifestation of our patient with multiple endocrine neoplasia type 1. And we have to exclude all of the MEN syndromes. And we also have to exclude familial hypocalciuric hypercalcemia, where there is a problem with the ability of the parathyroid, the chief cell, to be able to sense what's happening with serum calcium. And so if there is a mutation in the calcium sensing receptor gene or the GNA11 or the AP2S1 genes, then the ability of that chief cell to be able to sense that serum calcium and suppress PTH is going to be affected. And remember, the calcium sensing receptor is also in the kidney. So normally when calcium levels rise, this is associated with an increase in urine calcium. But if there's an inactivating mutation of the calcium sensing receptor, and it is less sensitive to the effects of calcium, it's not going to be able to turn off PTH. And when the calcium will rise in the kidney, if you have an inactivating mutation of the calcium sensing receptor, you're going to have increases in urine calcium. And so when that calcium will go up, we're going to have, normally we have hypercalciuria, and if you have an inactivating mutation, you will have a relative hypocalciuria because the receptor is not recognizing that calcium. So the ability to eliminate that calcium is going to be impaired. In multiple endocrine neoplasia, the tumors tend to be multifocal and multiglandular. And remember, you can have up to 1/3 of patients who have MEN1 who are genotype negative. And so if your patient has primary hyperparathyroidism and a pituitary adenoma, then we need to follow these patients because we can make the clinical diagnosis of MEN1 in these patients. So let's talk about FHH. So there are 3 forms of FHH. And also in a non-syndromic situation, we can also have familial isolated hyperparathyroidism. And these patients may have an MEN1 gene mutation. And instead of having the multiple effects of MEN1, they can just have isolated, familial isolated hyperparathyroidism. And non-syndromic, another condition which is non-syndromic primary hyperparathyroidism, is neonatal severe hyperparathyroidism. So coming back to FHH, so we have an inactivating mutation of the calcium sensing receptor. And now the calcium levels are rising, but they're not being sensed by the receptor. And so we're not able to turn off PTH. And we are seeing rises in the calcium in the kidney, the amount of calcium that is being delivered to the kidney, and we're not able to increase urine calcium excretion. And so we have a relative hypocalciuria. And that is the clue that this patient doesn't have primary hyperparathyroidism. So we need to calculate the calcium to creatinine clearance ratio, urine calcium times the plasma creatinine, have everything in millimoles divided by the urine creatinine times the plasma calcium corrected. And in primary hyperparathyroidism, usually the calcium to creatinine clearance ratio is more than 0.02. And there is, you're able to eliminate that calcium because the calcium sensing receptor is functioning normally. But in FHH, the calcium sensing receptor is less sensitive. So there is a relative hypocalciuria. Calcium levels are high, but the ability of the kidney to get rid of that calcium is impaired because there's an inactivating mutation of the calcium sensing receptor. And we say that the calcium to creatinine clearance ratio is less than 0.01. But the sensitivity and specificity for this is not 100%. And so we actually find that 40% of patients with primary hyperparathyroidism and 40% of patients with familial hypocalciuric hypercalcemia are in the gray zone between 0.01 and 0.02. And we have patients who have a molecular diagnosis confirming that they do have an inactivating mutation of the calcium sensing receptor gene, and they have a calcium to creatinine clearance ratio of more than 0.02. And the two conditions can coexist as well. And there can be racial differences, and Blacks can have a lower calcium to creatinine clearance ratio. So if you are in doubt, before you send your patient for surgery, check for other causes of a low calcium to creatinine clearance ratio. What are other causes? Well, maybe your patient has chronic kidney disease. Maybe your patient has vitamin D insufficiency. Maybe your patient has very low calcium intake. These are other reasons that can cause a low calcium to creatinine clearance ratio, and we should correct them. And also it could be racial differences. And if you've corrected everything, then you can just go ahead and do the DNA analysis, and you're going to be looking for those 3 genes. So always consider FHH, especially if your patient has had lifelong hypercalcemia. So this is a useful time to ask the family doctor, did you check the serum calcium before? And what was it? And if you have old records, it can be very helpful, or a positive family history, but it could always be a de novo mutation. And then we would do the DNA analysis for the calcium sensing receptor gene, GNA11, and AP2S1 genes. All right, so with FHH, this is hypercalcemia in isolation. This is non-syndromic. There are no other abnormalities on examination, and we see a higher level of calcium is required to activate the calcium sensing receptor and to decrease PTH synthesis and secretion. The most common FHH is FHH1. And this is associated with a loss of function mutation in the calcium sensing receptor gene. This is autosomal dominant, and it is still not common. You know, primary hyperparathyroidism has a prevalence of about 1%, and FHH1 has a prevalence of about 70 per 100,000. So it's not that common, but we must exclude this before we send our patients for surgery. And usually these patients have mild hypercalcemia, but any young person who presents with hypercalcemia, we have to be sure that we have excluded FHH and multiple endocrine neoplasia. So our patient who was this young woman presenting with very severe hypercalcemia, we know she doesn't have FHH because you don't see that degree of hypercalcemia in FHH. FHH2, you can have a loss of function mutation in the GNA11 gene, and this encodes G protein alpha 11 subunit, and there's only a handful of published cases. And then we have FHH3, a loss of function mutation in the AP2S1 gene, and this is really rare, like 1 in 100,000. And familial isolated hyperparathyroidism. So you have a family history. The patient said, yeah, my dad had this too. And you should do the DNA studies, and you will see a mutation in either calcium sensing receptor gene or the MEN1 gene or the CDC73 gene in up to 1/3 of these patients. So it is important to do the DNA analysis. And 10% of patients who have primary hyperparathyroidism under the age of 45 will have a mutation in one of those genes. So we also have to exclude MEN1, 2, 4, and 5. MEN3 is not usually associated with parathyroid disease, but always remember that different diseases can coexist. And it's important to, keep an open mind. I don't know what the problem is. But in MEN1, we have a loss of function mutation in the MEN1 gene. And so this gene will encode the tumor suppressive protein menin. And these patients are almost all of them, more than 90%, will have primary hyperparathyroidism by age 70. And they can also have pituitary tumors and enteropancreatic neuroendocrine tumors. And so those are the 3 cardinal tumors that can happen with MEN1. And they can also have lung carcinoid, lipomas, meningiomas, adrenocortical tumors, and facial angiofibromas can happen. And if your patient does have MEN1, these patients have to have open parathyroidectomy with exploration of all 4 parathyroid glands. And we usually recommend that 3.5 of the parathyroid glands be taken out. So these patients are not suitable for the minimally invasive procedure, and you should send your patient to an expert parathyroid surgeon. With MEN2, a gain of function mutation in the RET oncogene, and 95% of these patients will develop medullary thyroid cancer, pheochromocytoma, 50%, and parathyroid adenoma 5 to 15%. Usually they can be multiglandular, and hyperplasia can also be present. With MEN4, loss of function mutation in the CDKN1B gene, and these patients can have parathyroid, pituitary, adrenal, renal, and reproductive organs, and pancreatic neuroendocrine tumors as well. And 75% of these patients can have primary hyperparathyroidism. So typically you're looking at MEN1, MEN4. Those are going to be your most common causes with MEN. MEN5, paragangliomas, PHO, primary hyperpara, not as commonly seen, pituitary and pancreatic neuroendocrine tumors. There's another condition, the hyperparathyroid jaw tumor syndrome. And in this condition, this is a loss of function mutation in the CDC73 gene. And this affects the parafibromin levels, which is a tumor suppressor protein, and patients can have parathyroid adenomas. The problem is that these patients are more likely to have malignancy. Parathyroid cancer is rare. Less than 1% of patients with primary hyperparathyroidism will have parathyroid cancer. But in hyperparathyroid jaw tumor syndrome, they're more likely to have parathyroid cancer. They can also have benign ossifying mandible fibromas and renal cysts. So we should also be looking at the kidneys closely and do a renal ultrasound. And as I mentioned, MEN3 is usually not associated with parathyroid disease. So we should do a screen for MEN1. Yeah, I don't know what the problem is.
Yeah, as soon as that's where it comes on, so it's got to be a connection here. We'll just have a look at it.
Yeah,
Let's move this over a little.
that's a good idea. Okay.
Okay.
Let's see if this works. So with MEN1, remember it could be, the three cardinal tumors of parathyroid, pituitary, and pancreatic. You can also have other tumors, carcinoid tumor of the bronchus or thymus or duodenum. And so the screening includes, in addition to the calcium and the PTH, prolactin, gastrin, glucagon, insulin, glucose, chromogranin A, and an MRI of the head and CT of the chest and abdomen. And remember, we can make this diagnosis clinically in the presence of 2 out of the 3 cardinal tumors. And if we are looking for MEN genetic testing, we would do the MEN1 gene testing, the RET oncogene, CDKN1B looking for MEN4, CDC73 for hyperparathyroid jaw tumor syndrome, and then the 3 genes for FHH, calcium sensing receptor, GNA11, and AP2S1. We usually send our lab to Prevention Genetics and get them all done there. Remember with primary hyperparathyroidism, this osteitis fibrosa cystica, these osteoclastomas can be seen. And, we always say, oh, well, we really don't see this in Canada. It happens in underdeveloped countries where they don't have the ability to check calcium and PTH and make the diagnosis early. Well, it happens everywhere. And our patient presented at McMaster because of leg pain. And that actually turned out to be an osteoclastoma. But, you can have these brown tumors in the forearm. You can also have this osteitis fibrosa cystica with distal clavicle tapering and subperiosteal bone resorption, and the salt and pepper skull with diffuse demineralization. And when you correct the underlying primary hyperparathyroidism, these lesions all heal up. So I'm going to show you, we're going to publish our case and show subsequent images to see how quickly this patient has recovery of these large lytic lesions. So how do we evaluate patients with primary hyperparathyroidism? Well, we need to confirm the diagnosis, and we need to ensure that if it is a syndromic condition, that we exclude MEN. If it's non-syndromic, that we make sure that our patient doesn't have FHH. With skeletal imaging, we should do a 3-site DEXA. And just doing the spine and the hip is not enough, because the 1/3 radial site is 99% cortical bone, and it is a site which is enriched with PTH receptors. And so the 1/3 radial site is going to be preferentially demineralized. So you do need to do a 3-site bone density assessment on these patients. Just doing a hip and spine BMD is not enough. And you should also evaluate the lumbar spine with x-rays to make sure that the patient has not had vertebral fractures. And if you have trabecular bone score available to you, then certainly supplement that, because there are changes in the microstructure of the skeleton that will be detected and identified on trabecular bone score. So what is the effect of primary hyperparathyroidism? What are the organs that it's going to affect? Well, it's going to have a big impact on bone, and it's going to have a big impact on the kidney, in addition to other organs. So let's see what happens with the bone. The largest study that has been done looking at the effects of primary hyperparathyroidism on the bone is the Scandinavian Investigation of Primary Hyperparathyroidism study. This is the largest and the longest RCT study looking at surgery versus observation. And this study was a 10-year prospective study. It was published in the Annals of Internal Medicine in 2022 and involved an RCT study of 191 patients who had asymptomatic disease. These are not people with symptomatic hypercalcemia. These people had mild hypercalcemia. They were enrolled if their calcium corrected was less than 2.8. Otherwise, they were not included. So they had to have asymptomatic disease, and they were people between the ages of 50 and 80. And if they had kidney stones or chronic kidney disease, they were not included. So they had to truly be asymptomatic. And this is what was seen. So if you follow these people with mild primary hyperparathyroidism, what happens to them over 10 years? Well, they don't do too badly. You know, there was no difference in cardiovascular or cerebrovascular mortality. Morbidity and overall mortality was low, and there was no difference in the people who went on to have parathyroidectomy and the people who were observed. What about fractures? Do we have fewer fractures in the people who have parathyroidectomy? Well, actually, no. There was no difference in peripheral or vertebral fractures. There was a limitation in that 23 patients in the parathyroidectomy arm and 27 patients in the observation arm withdrew from the study. So, you know, we're losing about a quarter of the patients. So that was unfortunately a limitation. But medical observation does appear to be safe in people with mild primary hyperparathyroidism. And so how can we apply this? Well, if your patient has comorbidity and cannot have surgery safely or doesn't want to have surgery, if they have mild disease, you can watch them. If your patient has multiple endocrine neoplasia and already has had surgery and they now have recurrent disease, because most people will have recurrent disease, half of them will recur in 10 years. And if they have mild hypercalcemia, you don't need to jump in and repeat surgery, because then you'll make them hypopara. And so you could potentially just watch them if they have relatively well-maintained skeletal status and their kidney function is reasonable and they haven't had recurrent kidney stones. So this was an important study, and that, you know, it tells us that we don't need to rush for surgery if they have mild disease. We do need to monitor renal function. We need to look at the stone profile in these patients, look at the 24-hour urine calcium, and also check oxalate and citrate and uric acid, see if they have any other reasons to develop kidney stones, because that is important, and do a renal ultrasound. Look to see if they have nephrocalcinosis or nephrolithiasis, because you need that information to decide if they need to go for surgery. What about the non-classical manifestations? What about mild hypercalcemia causing cognitive impairment, confusion, anxiety? Well, we don't have data to support routine evaluation for that, and we don't really have enough data to recommend surgery on that basis. So when I present the surgical criteria, you'll see that we're really focusing more on the degree of hypercalcemia and on the renal and the skeletal effects of primary hyperparathyroidism. So renal stones are more commonly seen in people with primary hyperparathyroidism. Overt stone disease has decreased from 80%, which was the case maybe 50 years ago, to current values, which are in the 7 to 20% prevalence of kidney stones. In the normal population, in the eukαλemic general population, the prevalence of kidney stones is 1.6%. So people with primary hyperparathyroidism are more likely to have kidney stones, 7 to 20%. And they're more common in younger men with primary hyperparathyroidism. And what has been found is that hypercalciuria is more prevalent in stone formers. So if your patient has significant hypercalciuria, then this is a factor that will increase, that is predictive of an increased risk of kidney stones. And what we've seen is that after parathyroidectomy, the risk of kidney stones goes down, but it doesn't normalize. So, we do need to continue to monitor these patients. And we recognize also that in those patients who have a stage 3 chronic kidney disease or more advanced levels of stage 3 or 4 or 5, obviously they're going to be associated with more severe bone disease. So having renal impairment as an important predictor of problems to come with untreated primary hyperparathyroidism. So parathyroidectomy has been associated with renal protection. Parathyroidectomy prevents declines in renal function, and we have seen in retrospective cross-sectional data that it will preserve renal function. The neurocognitive manifestations, we need more evidence to determine the relationship and the reversibility of these features with parathyroidectomy. Oftentimes we're asked, in elderly patients who might have primary hyperparathyroidism, is it worth them having parathyroid surgery and correcting the hypercalcemia? Will this be associated with improvements in their cognition? And if you want to really know what will happen, you can just treat their hypercalcemia with cinacalcet. Give them cinacalcet, normalize their calcium. If the cognition doesn't get any better, then going for parathyroidectomy is not going to help them. Okay, so let's move on. So what are the clinical phenotypes of primary hyperparathyroidism? Our patient might have symptomatic disease. Symptomatic disease, they've had skeletal involvement with fractures, or they have osteoporosis. They have renal complications with kidney stones. They could also have chronic kidney disease, nephrolithiasis, nephrocalcinosis, and overt skeletal disease is osteitis fibrosa cystica, which is what our patient presented with. Now, they might have asymptomatic primary hyperparathyroidism. They feel great. They don't have osteoporosis. They've never had kidney stones. Their kidney function is normal. And what do we do with these people? Well, we should evaluate them. We need to do a bone density. We should do spine x-ray, see if they've had any fractures that are silent. About 2/3 of vertebral fractures are silent. We should do a renal ultrasound and see if they have renal involvement. And if we find evidence of complications, then we would describe them as having asymptomatic disease with target organ involvement. They're still asymptomatic. They didn't know that they had that. Or they could have, their ultrasound is good, their bone health is good. They could have asymptomatic disease without target organ involvement. Now, we also have another condition, normal calcemic hyperparathyroidism. I actually don't like to call this normal calcemic primary hyperparathyroidism, because to be primary hyperparathyroidism, we just said you have to be hypercalcemic. So it's a bit of a misnomer. But normal calcemic hyperparathyroidism is confirmed in a patient who has consistently normal calcium, but has elevations in PTH. And this could be measured with a second or a third generation assay on at least 2 occasions. over several months, 3 to 6 months. And we have to make sure that our patient does not have a physiologic rise for this elevation in PTH. Does our patient have vitamin D insufficiency? Is the 25 hydroxy vitamin D below 75 nanomoles per liter? If it is, then we have to correct it before we make this diagnosis. Does our patient have chronic kidney disease stage 3 or worse? If it is, we can't make that diagnosis. They have a physiologic cause for a high PTH. Does a patient take medications such as hydrochlorothiazide or lithium? Then we have to, try and stop the hydrochlorothiazide. It's hard to take people off lithium. And if they're on lithium, I would just assume it's in association with the lithium and not try and get them off it. It can be very difficult to try and get them off the lithium. Are they on antiresorptives? If they're on denosumab or bisphosphonates, that can result in a physiologic rise in PTH, especially if our patient isn't getting adequate calcium or vitamin D. And we would not make that diagnosis of normal calcemic hyperparathyroidism in a patient who's on antiresorptive therapy because they have a reason for a physiologic rise in PTH. If they have hypercalciuria, they're losing calcium. The PTH will go up because they have to remove calcium from the skeleton to cover for the deficit. So that can be associated with a rise in PTH. And if they have malabsorption, maybe they have celiac disease, and how will you know that they're not getting enough calcium or they're not absorbing it? You can look at the urine calcium. If the urine calcium is low, then you can try and increase the calcium supplement, give them more calcium supplements, and try and normalize that urine calcium. But if it's still low, then that could be a cause for the high PTH. So if the urine calcium is not normal, it's not possible to make this diagnosis. And please don't send them for surgery. We do not have sufficient data to make surgical recommendations for people with normal calcemic hyperparathyroidism. I have been asked to see so many patients who had normal calcemic hyperparathyroidism, went to a surgeon, and now have hypoparathyroidism. And there's a center in the US that likes to whip out parathyroid glands. As long as you have a high PTH, that's enough criteria for them to go ahead and do a subtotal parathyroidectomy. And this is pure malpractice. And many of these patients become hypoparathyroid, and there are many Canadians who go down there because they have a really flashy website. So please make sure that patients with normal calcemic hyperparathyroidism are not sent for surgery. And do the genetic evaluation in young people, especially, and those with the multiglandular disease, and in those who have a family history or syndromic disease. So who goes for surgery? What are the new criteria? If you have significant hypercalcemia, then it makes sense to go for surgery unless you have a reason not to go for surgery, such as significant comorbidity. So if your calcium is more than 0.25 millimoles per liter above the upper level of normal, then you should consider surgery. Skeletal involvement, if you've had a fracture, and this could be a silent vertebral fracture on spinal imaging or on VFA, or you've had an appendicular low trauma fracture with a fall from standing height, or you have evidence of osteoporosis. Remember, not just lumbar spine and hip, but you also have to do the 1/3 radial site to apply these criteria. If you have renal involvement, if you have stage 3 chronic kidney disease, or nephrocalcinosis or nephrolithiasis, or hypercalciuria, then you should go for surgery. You should be considered for surgery. And if you're younger than the age of 50, we do recommend surgery because we don't know what happens with decades of mild primary hyperparathyroidism. Now, even if you don't meet any of these criteria, and you want to have surgery because you have an abnormality, you have a hormonal abnormality that can be surgically corrected, then you can always go for surgery, but it is very important to go and see an experienced parathyroid surgeon. So these are the recommendations. So what is new in the recommendations? The recommendations and options for medical intervention are new. And we also made new recommendations for pregnancy. So what is the role of non-surgical medical management? Well, we do have evidence that we can provide skeletal protection. High levels of PTH will bind to the osteoblast. PTH binds to osteoblasts. There are PTH receptors in osteoblasts. It increases rank ligand expression, and it causes bone resorption. Can we protect the skeleton? Well, yes, we can give a bisphosphonate. A nitrogen-containing bisphosphonate can be given orally. We have data with alendronate, and there's also some data with residronate, and it will bind to the hydroxyapatite crystal when the osteoclast comes and attaches to the surface of the bone and releases acid and enzymes and causes bone resorption. It ingests the bisphosphonate, and the bisphosphonate will cause osteoclast apoptosis, and the osteoclast will die. And in patients with primary hyperparathyroidism, bone resorption is higher than bone formation. So we need to knock out these excess osteoclasts, and we can do that with a bisphosphonate. Now, will that correct the hypercalcemia? No, because we've got increased calcium reabsorption through the kidney. So we've prevented calcium release from the skeleton, but we're still increasing calcium reabsorption through the kidney, and we still have increased 125D levels, which is enhancing calcium absorption from the bowel, calcium and phosphate absorption from the bowel. What about denosumab? Well, denosumab will provide skeletal protection, but it too will not normalize calcium or PTH. What about cinacalcet? Well, cinacalcet is a very valuable drug. It's a positive allosteric modulator of the calcium sensing receptor. And it is capable of decreasing the synthesis and secretion of PTH, and it will decrease PTH, and it will normalize serum calcium. And you can combine cinacalcet with the bisphosphonate. You could combine it with denosumab, because cinacalcet does not provide skeletal protection. So if you combine cinacalcet with denosumab, that's like a chemical parathyroidectomy. And that would be a useful approach. What about calcium supplements? Well, we advise our patients to take calcium from dietary sources and meet the Institute of Medicine nutritional guidelines, because if they're on a deprived calcium intake, that will result in further elevations in PTH. And we also recommend that they get adequate vitamin D, and that they be replete in vitamin D, because patients who have inadequate levels of vitamin D will have larger parathyroid adenoma size and weight. So they should be vitamin D replete, and there's no harm in giving vitamin D supplementation to patients who have mild hypercalcemia or even moderate hypercalcemia if the vitamin D levels are low. And it is important to correct the vitamin D insufficiency, because they'll have more severe hungry bone syndrome after parathyroidectomy otherwise. So correct the vitamin D insufficiency and make sure that they're getting adequate calcium from dietary sources. So here is the data with these drugs. We have data with alendronate showing that bone density will improve. We have data with estrogen and raloxifene, small studies, very small studies actually, showing that we can preserve bone density. With cinacalcet, we can decrease calcium and PTH. With denosumab, we can increase bone density. And with vitamin D, it's really a very limited study, so it really doesn't do very much. So here's the data with alendronate. And you can see this was our multi-center trial, and we showed that alendronate, in comparison to placebo, provides improvements in bone density at the lumbar spine and also at the total hip. And there was no change in calcium or PTH. With cinacalcet, did it decide to come up?
There you go. Yeah. Back on.
Here we go.
Must be very tight.
Yeah. So with cinacalcet, it's a positive allosteric modulator. It increases the sensitivity of the calcium sensing receptor. And therefore, the calcium is able to decrease PTH synthesis and secretion. And in the kidney, it will increase the sensitivity of the calcium sensing receptor, and it will increase urine calcium excretion. And so cinacalcet is able to drop calcium. And this is from our phase 3 double-blind RCT study, looking at cinacalcet 30 milligrams twice a day. And the dose was adjusted every 3 weeks. The maximum was 90 milligrams TID. For patients with parathyroid cancer, cinacalcet can be really very helpful. And you can go up even higher. You can give them cinacalcet and denosumab. There's only so much you can take out. And when they have metastatic disease, this can be very helpful to patients. But cinacalcet is going to have an impact. Usually when I start cinacalcet, I actually start with half a tablet. I tell my patients just take half a tablet, take the 30 milligram, break it into half, take 15 milligrams just once a day, because you can easily overshoot. And if they have mild hypercalcemia, they can become hypocalcemic because it's a very powerful drug. And you need to recognize that it will have an impact on lowering serum calcium very quickly. So let's see a little bit about pregnancy. So in pregnancy, we have the release of PTHrP from the breast and the placenta. And these levels of PTHrP will rise from the 3rd to the 13th week of gestation. And what this will do, PTHrP acts like PTH, and it can enhance the formation of 125D. And it can also contribute to bone resorption, and it can further increase calcium and phosphate absorption and cause an absorptive hypercalciuria. So the diagnosis of primary hyperparathyroidism in pregnancy is also a biochemical diagnosis, as always. We never do imaging. So many times people say, oh, I'm going to do a sesame scan. I don't know what's going on with my patient. And if I see a parathyroid adenoma, then I have my diagnosis. Well, the sesame scanning has very poor sensitivity and specificity, and it can light up with thyroid adenomas as well. It can miss small parathyroid adenomas, and it can also miss hyperplasia. It is always a biochemical diagnosis, even in pregnancy. But remember, what happens is that because of the rises in PTHrP, PTH levels may slightly come down. And so then you're looking at a patient who has hypercalcemia and a PTH that is not that high. But if it's in the upper level of normal or slightly elevated, then you can say, okay, you do have primary hyperparathyroidism. It obviously wasn't a concern in our patient. The level was like 40 times normal. Imaging tools, you can look at neck ultrasound. You can certainly do kidney ultrasound. Sesame scanning is contraindicated. You can do a CT of the neck. It is believed to be safe with very low dose fetal radiation exposure. So you can do that. And then the general measures are important. Rehydrate the patient. Stop calcium supplements and hydrochlorothiazide and lithium if possible. Correct the vitamin D inadequacy. And these are your options. You can give calcitonin. You have to give large doses of calcitonin. Calcitonin causes nausea. But in a patient with hypercalcemia, it's your best bet of dropping that calcium quickly within 24 to 48 hours. So you start calcitonin right away while you're hydrating your patient. Look at the doses. You have to give large doses, 4 to 8 international units per kilogram. So you're giving like 200 international units, and you can give it, every 12 hours. Cinacalcet is a category C drug. There are a handful of cases where cinacalcet has been used in pregnancy. And we did give this patient cinacalcet while we were preparing her for surgery, because we started her on calcitonin. We began to rehydrate her, and we also gave her some cinacalcet because the calcium was so high. Bisphosphonates are not going to kick in till at least day 2, 3, 4. And denosumab is useful, but obviously is not going to be used in pregnancy. And we don't recommend phosphate supplementation. So if your patient is pregnant and has mild primary hyperparathyroidism, what do you do? Well, you should have diagnosed it before they became pregnant, but in a patient like this, hydrate them, make sure that they are well hydrated, and follow them. And if you absolutely need to do surgery, then you should ideally do surgery in the second trimester. That is the best time to do surgery. In our patient, we had to do it in the 3rd trimester because she was so severely hypercalcemic. And in our patient, we sent her for surgery, and she did have a CT of the neck done. Prior to surgery, she had a 3 by 4 centimeter right paratracheal mass. And this femoral shaft lesion could be a brown tumor or parathyroid cancer mets. And the final pathology was that she had a parathyroid adenoma. It was a huge adenoma, and that was a brown tumor that she had. And she's doing great, and she's done really well. So the case revisited had a happy ending. So the take-home message is primary hyperparathyroidism requires careful evaluation with exclusion of genetic causes in those with a positive family history and features of syndromic disease, as well as young people. It's the most common cause of hypercalcemia. So if your patient has hypercalcemia and they are looking pretty good, then it's probably primary hyperparathyroidism. If they're looking bad, it's probably cancer. Parathyroidectomy is an attractive option, definitely for symptomatic, but even for asymptomatic, if you have access to a good surgeon, which we've really emphasized, medical intervention can delay initial therapy and delay repeat parathyroidectomy. In patients with MEN, we like to delay that repeat surgery. There's only so much you can go in and keep chopping out. Approximately 50% of patients with primary hyperpara and MEN will have recurrent disease in 10 years. So by delaying the repeat surgery with cinacalcet, with denosumab, with IV zoledronic acid, we can really buy some time and prevent hypoparathyroidism. Nitrogen-containing bisphosphonates and denosumab can provide skeletal protection. Cinacalcet lowers PTH and calcium often into the normal range. And these patients need to be closely followed. And during pregnancy, monitor them closely. And if patients are hypercalcemic, those babies can be born with hypoparathyroidism because the baby's parathyroid gland doesn't develop. So it's really important to try and correct it prior to the onset of the pregnancy. But if you need to do a parathyroidectomy, the second trimester is the best time to do it. And you would do it if they are significantly hypercalcemic. Otherwise, just watch them and check the baby's calcium when they're born. So with that, I'd like to thank you for your attention. I'm happy to answer questions.
We have a few minutes for questions. Monica?
Thank you. That's an amazing talk, and I have lots of questions, but I'm just going to focus on the pregnancy piece. That 2.75 threshold, if the hypercalcemia is milder than that, is there still no risk of suppressing the fetal parathyroid?
Probably probably the benefit of surgery is going to, it's not going to be sufficient to warrant surgery. So if the mild hypercalcemia is there, you can just watch these patients. And I have watched a number of them with mild hypercalcemia, and the babies tend to be okay. So I wouldn't recommend surgery. The benefit is not going to be outweighed by the risk. So, but if they have more significant hypercalcemia, and that was the consensus that I presented to you, the 2.75, that was the consensus from the International Working Group on Primary Hyperparathyroidism. Others in the group, including myself, I would have accepted 2.85. But, the Europeans said, no, we got to do the surgery early. So we said, okay, it has to be an international consensus. So we said 2.75. But if that is still considered mild, then the baby should be okay. It's typically you're going to have the fetal parathyroid glands will not develop if the patient is more significantly hypercalcemic. But even our patient, that baby's parathyroid glands were fine. And that patient had a calcium of 4. So there's a lot of variation, and yeah, they can be safely followed, I would say.
Thanks so much for the talk. I just have a question about the Scandinavian study that you showed.
Yes.
The control group, they were not treated with any bisphosphonates.
No, they were purely observed.
And so would they they wouldn't have met that like T-score less than 2.5, but would some of them have been in the kind of osteopenia kind of?
Yes, yes.
Okay.
Yes, correct. Yeah.
So the medical therapy of hyperparathyroidism, there must be patients who meet the indication for surgery who say they don't want surgery.
Yes.
Is there a study now looking at those patients to see because at least 15 years ago, there was no medical therapy
Yes.
for hyperparathyroidism. So is there now an organized way of following these patients?
Yeah, and so what we recommended in the guidelines is to monitor their bone density and their kidney function and monitor renal status as well. And so we are recommending that the bone density be done every maybe 1 or 2 years. And if they are experiencing progressive declines in bone density or they have fractures, then you want to revisit that. The medical management is pretty good, though, I have to say, with the denosumab. They will typically do well. And you can correct their hypercalcemia with the cinacalcet. So now that medical management has really improved, you could follow these people if they don't want to have surgery. And we do have a number of these patients. The studies that have been done are still small. And so we are collecting this data with combination therapy. The studies have been done on like 20, 40, 50 patients, not large studies. And so these patients are being followed. And typically, I would say skeletal health can be protected, but kidney disease progresses and the GFR goes down and they can get kidney calcification, nephrocalcinosis, calcification of the renal parenchyma and kidney stones. And that will result in declines in kidney function, which would have been prevented by the parathyroidectomy. So it's, if they don't have comorbidity and you've got access to a good surgeon, the whole problem can be corrected. And which would be ideal.
I guess what I'm saying is individually people will follow.
Yes.
But is there a way of entering your patient who decides no surgery from their patient?
Into a registry? Yeah. We don't have an organized registry right now. The Italians have a registry and they are looking at those patients. But, we could certainly organize something like that through the Canadian Society of Endocrinology and Metabolism and collect data on these patients. It's a very good question that you raise, looking to see what happens with these people. Certainly now that we do have cinacalcet and denosumab, that we can provide them with fairly good medical therapy, how do they do, and follow these patients. I think that is definitely a very valuable approach that we could obtain that data.
I'm going to ask you a clinical question. This is a colleague of mine's patient, so I don't know all the details, but my colleague recently saw a woman who I don't think has fractured, but has a bone density, and her T-score at the spine is minus 5.5. And then she was found to have mild hypercalcemia, elevated PTH, and a 24-hour urine that is in that indeterminate range of like 1.1%. And so my colleague is considering using romosozumab. Still wants to send her to surgery, wants to get genetic testing to make sure it's not FHH, given how low the fractional excretion of calcium is. In BC, we have, I don't know if you've heard about our pharmacare woos, but if we prescribe a bisphosphonate while we try to figure things out, that patient gets excluded from the possibility of using Romo. So I think he doesn't want to use the wrong drug first. Would you have any concerns about using romosozumab in a patient like this?
How old is she?
I don't know. Let's say 65.
65. Well,
it's hard to believe that T-score of minus 5.5 is purely based on mild hyperparathyroidism. So it's probably real, something real underneath too.
Well, it would be interesting to know what the 1/3 radial site is, because that'll tell you how much of this is likely to be primary hyperpara versus other secondary causes of osteoporosis. But I wouldn't use Romo because after parathyroidectomy, if parathyroidectomy is on the table, there's a 10% increase in bone density over the next 10 years. And that natural accrual in bone formation, may not happen in the presence of anti-resorptive therapy. And Romo has anti-resorptive and anabolic effects. So I think that we shouldn't worry too much about, what the access to drug therapy is. We should think, and I know we need to worry about it because otherwise the patient can't access it, but we should think from a scientific perspective, what's the best treatment for this patient? I wouldn't jump in with Roma just because I might not be able to get it from my patient afterwards. I would look at that 1/3 radial side. I would understand what else is going on. And if that patient does have primary hyperparathyroidism and surgery is going to be of value, I would send that patient for surgery. And then after surgery, see how much of an increase we get in. Yeah.
Yeah, I'm just thinking like logistically 10% over a number of years or 15% in the first year.
Yeah, but you don't know what you're dealing with. Yeah, but you don't know what you're dealing with. So I'd like to have a better idea as to what am I dealing with? What is the DNA analysis showing? What are the other reasons for this person to have a T-score of minus 5.5 at the lumbar spine? If the 1/3 radial side is relatively well maintained, there's definitely more things going on. Yeah.
We can do questions back. Officially, it's 1:07. So again, Dr. Khan, thank you so much. That was thorough. There's probably more questions out there. I have one more. Thank you. Protocol as far as when we treat them with bisphosphonate before their parathyroid surgery, because I know our surgeons don't like.
Know that.
Yeah, they get really upset.
That prevents
Yeah.
that natural increase in bone formation
Yeah.
that are cool that can happen.
Yeah.
After parathyroid, the osteocytes know
Yeah.
that there's less bone.